Hello, my name is Javad Parvizi. I'm a professor of orthopedic surgery working at Acıbadem University in Istanbul. Today, I have the distinct pleasure of talking to one of my great friends, Dr. James Cashman from Ireland. Jimmy has done has made an amazing contribution to the field of orthopedics, in particular PJI. He's a spectacular surgeon, but more importantly, he's an amazing friend. He was assigned one of the most difficult questions in ICM, which is what are the indications for DAIR? And he and his delegates that were assigned to him spent a long few months to review the literature and come up with the answer. Jimmy, it's a pleasure to have you on this podcast. Thank you for
Thank you
taking
for having me.
time in the middle of your busy day, I'm sure. So, what are the indications for there? What did you guys decide?
So we conducted our review, retrieving approximately 1,800 articles, and in our final review, we got it down to 260 articles for screening and 61 approximately publications in the end. And we covered a broad range of literature to look at this topic. And there's a wide variety of individual papers that support multiple different approaches to this. In terms of our final response, though, the statement that we had is that in general, all patients with the acute onset of infection and with a stable prosthesis are candidates for DAIR. However, the expected infection eradication rate depends on several patient and infection characteristics. So there were a couple of patient cohorts for whom DAIR you can expect a better result, and those principally would be infection within 6 weeks of an index arthroplasty, infection with the onset of symptoms within 7 days in an established arthroplasty, with well fixed and stable implants, acknowledging that exceptions may apply to these criteria.
Yeah, that's interesting that you went to 6 weeks because the 2018 was 4 weeks. And I know this is an arbitrary division by obviously, we all recognize that. But this time you went to 6 weeks. What was the rationale for the 6 weeks based on the literature that you did, I guess?
So one of the problems with the heterogeneity in the literature is that there's a wide range of cutoffs applied in studying this topic, and the truth of the matter is there is no one a gross overall cutoff, and in fact, it's a spectrum, and that spectrum applies to the several patient and infection microbial characteristics related to any particular infection. And then at the other extreme, you can look at some of the data that comes out of Holland, and the Dutch groups would say that you can do a DARE in anyone, and they you can expect a good result even much later after the 6 week mark. So on collating all these factors, we felt that 6 weeks is probably a compromise, realizing that you're not going to get a fantastic eradication rate if you take it longer than that.
Yeah, that's interesting. And I think you made it very clear during discussions that time from index arthroplasty is only one of the metrics that determines the outcome of there. We have to, unfortunately or fortunately, choose a time interval because this way it gives some guidance to the orthopedic surgeons. But there are obviously many other factors that go into the success of DARE. And there are numerous questions related to DARE in the ICM document, including things like should you do it for hematogenous infection? Should you exchange a exchange a mobile parts? Can you do double DARE, etc. So just to summarize, I think you, after the review of extensive literature, whatever has been published, you obviously reviewed all of it. Your recommendations are if infection occurs within 6 weeks of index arthroplasty, if the onset of symptoms is less than 7 days, obviously well fixed and stable implants. But interesting, you also say the exceptions may apply. And I assume there you're thinking about what megaprosthesis, perhaps circumstances where you don't want to be taking out the implants if they're extremely challenging. Is that fair?
Absolutely. I mean, there are patients in whom revision surgery is going to be too burdensome or perhaps not feasible in any context. And in those patients, you're going to try and retain that prosthesis. And we did look at megaprostheses and multiply revised patients also. And in that instance where you do not want to do a revision, DAIR is certainly possible. It may not have the same success rates as in a primary arthroplasty, but it's feasible to undertake it in that context. Yes.
Yeah, fantastic. And I think there was 76.5% agreement with 11% abstaining. So that's a strong consensus. We can't thank you enough for your great work there, Jimmy. That gives us some ideas as to how to move forward dealing with these patients with challenging acute PJI. Um, and then I want to ask you one last question, and that is, what did you think of the consensus, and what did you find interesting, and what is your message to our audience, if any?
So, one of the interesting things about this topic in particular is it generated an awful lot of debate on the day. And the consensus that we reached on this document was not as high as some of the other statements. So, this is still an area for discussion and development. And I think the truth of this is that we're not ever going to reach a point where we're going to be able to say definitively DARE is going to be successful in one patient versus another. But our understanding of this will improve over time. I do think it is a really good technique to apply to acute infections, and I think our understanding of it will grow in time, hopefully at future ICMs.
Hopefully. You have a home in Istanbul. If you want to run away from your kitchen remodeling, you're welcome to come to Istanbul for a week or two until Fiona's done with remodeling the entire place. It's a pleasure, and I look forward to seeing you in Dallas. And you're incredible. Thank you, Jimmy, for everything you do for us. Thank you for making time to talk to me in the middle of your day, and looking forward to see you. Thank you.
Thanks so much.